I'm Dean Watson. A warm welcome to my Watson Headache colleagues and a special welcome to those of you who are joining me for the first time. The headache and migraine journey is a tough gig and it's not made any easier by misguided, ill-informed and archaic perceptions. These perceptions do a disservice to those afflicted by headache and migraine. The first of these is that cervical dysfunction does not play a causal role in primary headache conditions, that is migraine, tension headache, cluster headache and their derivatives. Now, primary headache is divided into three types: tension type headache, migraine, and a third primary group, and this group comprises cluster headache, chronic paroxysmal hemicrania, and a condition called SUNCT. Now, SUNCT is an acronym for short-lasting unilateral neuralgical headache attacks with conjunctival tearing. Now, because these headache types present in a very similar way, they're collectively referred to as the trigeminal autonomic cephalalgias. The traditional model of headache looks at these primary headache types as being separate entities with as yet unknown pathophysiologies. However, there's vigorous debate as to whether or not these headache types are just different presentations of the one disorder. Now, recent research supports that it is the latter. Now, using trigeminofacial brainstem reflexes, and in the case of migraine, primarily the nociceptive blink reflex, it's been shown that the brainstems in migraineurs are sensitised or hyperexcitable. Using the trigeminocervical reflex, another trigeminofacial brainstem reflex, it's been shown that the brainstems in tension headache sufferers are also hyperexcitable. Similarly, in cluster headache. Now, because chronic paroxysmal hemicrania and SUNCT, hemicrania continua, all present in a similar way to cluster headache, it could be hypothesised that these other headache types are also underpinned by a sensitised brainstem. Also, menstrual migraineurs. Using the trigeminocervical reflex, it's been shown that the brainstems in menstrual migraineurs are sensitised or hyperexcitable. This research supports those authorities who are suggesting that primary headache conditions are different expressions of the one disorder or process, where tension headache is at the beginning of this escalating process, and if this process goes on uninterrupted with increasing intensity and the number of associated symptoms, it culminates in migraine. This concept is known as the Convergence Hypothesis and it's gaining more credibility. However, the medical model of headache is still the dominant model. So we are saddled with a model that looks at primary headache as being separate entities with as yet different or unknown, with different pathophysiologies, unknown pathophysiologies. But let's stay with the current research. Now, I've talked a lot about a sensitised brainstem. So I've depicted a sensitised brainstem here, and you can, so here's the sensitised brainstem. Let's go back a little bit. Here we have the three branches of the trigeminal nerve, so the ophthalmic branch, the maxillary branch, and the mandibular branch, all conveying information from various systems, importantly blood vessels, meninges, the teeth, gums, sinuses, nasal mucosa, the visual system, the lacrimal apparatus, and so forth. So a host of information is conveyed by these three branches, and the trigeminal ganglion has a spinal tract which extends down to the top three levels of the spinal cord. So information from structures supplied by the trigeminal nerve pass through the top three levels of the spinal cord and then cross over and then up towards the cortex. Now, this area here is called the trigeminocervical nucleus because this is where the neurons in the dorsal horn of the top three levels of the spinal cord are receiving information from structures with a trigeminal innervation. They're also receiving information from structures supplied by one or more of the top three spinal nerves. So there is an overlapping or a convergence of information from the trigeminal system and information from structures supplied by the top three spinal nerves. Now, I liken the brainstem to an audio speaker. And a sensitised brainstem is an audio speaker where the volume control has been turned up. So if we have increased noise in the trigeminal system, so for example, blood vessel dilates in response to, let's say, a glass of red wine, this increased noise passes through a sensitised brainstem or an audio speaker with the volume control turned up and is amplified even further. Okay, so there's a virtual exaggeration of it, and then when it goes to the cortex interprets this dilatation of the blood vessel as being much, much more than what it is. Dangerous, in fact, a threat, and so the body's response to a threat is to create pain, in this case, head pain. So this is the current thinking about migraine. It's where it's a sensory processing disorder where information from the trigeminal system is exaggerated. It's an artificial exaggeration of this of what's going on in the trigeminal system.
However, a sensitised brainstem is not unique to migraine. Tension headache, cluster headache, menstrual migraine. This is not about a diagnosis. Optimal management surely is about identifying the reason for the sensitisation. Now, there are various reasons for sensitisation of the trigeminocervical nucleus or lower brainstem. Two are noxious, nociceptive, and they are the cervical afferents and the trigeminal afferents. And two are inhibitory, the serotonin system and the diffuse noxious inhibitory control system. So the trigeminocervical nucleus, which is the doorstep to the final common pathway for all headache and migraine, is influenced by these four systems. It could be sensitised as a result of insufficient serotonin, so it's a lack of inhibition. Similarly, it could be a lack of inhibition because of dysfunction of the diffuse noxious inhibitory control system, or it may well be sensitised because of a constant barrage of cervical afferents, noxious afferents, or trigeminal noxious afferents. Let's look at the role that cervical afferents may be playing. It's interesting when you look at the literature around great occipital nerve blocks and their effect on primary headache, because the research shows that long-term resolution occurs in migraineurs following great occipital nerve blocks. Similarly, those with cluster headache also get extended relief following great occipital nerve blocks. Likewise, SUNCT. So what's this telling us? Modification of cervical afferent inflammation is leading to long extended improvement in its extended freedom from headache. Similarly, occipital nerve stimulators, same story. What's happening here is we're modifying noxious cervical afferent input, and occipital nerve stimulators have been shown to be effective in those with hemicrania and cluster headache. Now, this research supports my clinical experience. My clinical experience of over 22,000 hours with 8,000 headache and migraine sufferers is that these primary headache types are underpinned or driven by noxious cervical afferent inflammation. However, I will let someone else have the last word on this. Peter Rothbart is an experienced, internationally recognised clinician and researcher, and his clinic revolves around anaesthetic blocks. And you can see there, his experience is in accordance with mine. His experience is that the vast majority of primary headache conditions are driven by cervical afferent, noxious cervical afferent inflammation. Upper cervical dysfunction is significantly underestimated in primary headache conditions. The evidence is there.